and Wpba. So this is about the workplace-based assessment and not related to the Badminton Association, which is very famous. Okay, so jokes apart, let's see how the trainees are trained, what are the people who are available on call, and what are the exams which are called as assessments there that the trainees have to go through to get the completion of training certificate, which is CCT. So welcome back to the college, guys. NHS is managed by Department of Health in London, right? So the Department of Health in the ministry, of course. Budget is taken care by the commissioning groups, which will be very commonly referred, and you must have seen it in many of the talks that you come across, right? So which is referred as CG in short form. So these commissioning groups are GP-led organizations, right? So they are led by the general practitioners there. Now, how is the structure of NHS? There are different types of hospitals. Like here in India, we have the rural and then the primary healthcare centers. So exactly in the same way. So they also have the primary hospitals wherein the GPs, the general practitioners work, and the basic uh, things that are done in those hospitals or the primary clinics are to diagnose a patient, to give the basic treatments, and if not treated properly or something is complicated, then referring the patient. Whereas in the secondary care hospitals, they have all the major specialties like surgery, OBGY, medicine, right? In the tertiary or the quaternary centers, there are special services and super specialties. Okay, so they involve the cardiologist, the neurologist, the IVF specialist, right? So this is the basic structure of the hospitals in NHS. Now there are some nurse-led clinics too. Okay, so for example, in the colposcopy centers or the hysteroscopy centers, many are led by the nurse, and the nurses there will do the required diagnostic test or the procedure that is required and will be referred back to their respective clinics. Okay, like after doing a colposcopy in the colposcopy clinic, these patients are again referred back to the hospital from where, or to the GPs who had referred to the colposcopy clinic. Okay. Also, sometimes they have seen that we have seen that in along with the ANC, the diabetic clinics run for the diabetic patients. So the patient when comes along with the ANC care has to go to a joint diabetic clinic too. So these nurses there take care of the sugar levels and also help in the treatments of the diabetic patients. Of course, when things become complicated or are not able to cover up, then the patients are referred to the respective doctors. Then the clinical team. There are different ways of working. So generally, they'll have specific working hours, and there is, of course, a shift team which has to work. So it can either be a 12-hour shift, it can either be OR, that means an operation room shift. The operation theaters, which are called as OTs, are called as ORs there. And there can even be shorter shifts in some organizations. Now, remember who are the people who are on call on one specific day. Say, for example, if the patient comes, what are the people, if you want to call on, are present there in the hospital? So there are registrars and there are SHOs. The tertiary hospitals have two-tier registrars. Okay, the junior registrar ST3 and to ST5, and the senior registrars from ST6 to ST7. While the district hospitals will have a single tier registrars, which is from the middle or the intermediate group, that is ST4 to ST5. The on-call consultant is generally available till 8 p.m. and after that is available on phone and has to come to the hospital within 30 minutes from calling if an emergency occurs. There is always an anesthetic registrar and an on-call consultant anesthetics who are available, and you know that whenever required, the anesthetic registrar also has to come and be present in the labor wards or in the emergency duties. The theatre staff, of course, the whole of the staff, the scrub nurse and the runner. Runner or the rotating nurse is the person who goes from one OR to another OR or brings in the required instruments just in case an emergency case is taken up in the operation room and something is needed. Now, there are different types of services that are given, right? So let us see what are the obstetric services. So in the obstetrics, there are people who are very low risk. So women who are very, very low risk for deliveries can be given an option of home births. There's another unit called as midwifery-led unit, which is a standalone or a co-located unit wherein the midwives will be taking care of that unit and the patients can opt for either a home birth or a midwifery-led unit. Okay. Of course, in the home births, the midwife has to go, the midwife of that area has to go and help the patients at homes too. But herein, in the midwifery-led unit, the patients need to be shifted to the midwifery unit. Generally, these midwifery units are near the hospitals. Just in case an emergency appears, they can be shifted to the hospital urgently. And the last ones are the consultant-led units, which are supposed to be taken up or followed up if you have a very high risk ANC patient, right? Now there are neonatal units. So remember, Not all the neonatal units have all the facilities. So you have to know which hospital you're working in and what type of facility that neonatal unit has, right? So if you have a very, very preterm baby, less than 28 weeks, the anterior hospital doesn't have a level 3 care in the neonatal unit. Of course, the baby needs to be shifted to the level 3 neonatal unit. Okay, so then the transfer forms and the formalities take place. The level 2 neonatal units take care of babies from 28 to 32 weeks and have the facilities associated with those babies. Level 1 is from 32 to 36 weeks, which has got all the basic cares that is required for the preterm baby, but of course doesn't have very high level of um, machines or instruments, or even the pediatricians which who can take care of a very complicated preterm babies, right? So level 1 is from 30 to 36 weeks. Level 2 taking care of babies from 28 to 32 weeks, and level 3 is taking care of babies born less than 28 weeks. The gynecological services are nurse-led clinics, early pregnancy assessment units. There can be outpatient clinics, there can be inpatient clinics in gynae, inpatient surgery units, office gynecology, or even special gynecological services. The EPAU, which is Early Pregnancy Assessment Unit, takes care of all the bleeding that occurs in the very early parts of the pregnancy, right? The early, uh, the first trimester of the pregnancy, if there is pain in abdomen, there is bleeding, these patients are referred for early pregnancy assessment unit. Now, foundation trainee, which is FY, okay, so there is a 2-year foundation program that is set up to ensure that all the newly qualified doctors, they follow a structured program of study and practical experience before progressing to the specialist training. Okay, so this is foundation training. So these are the doctors for 2 years before getting any practical experience. They are they know or they go through a structured program of study for 2 years. Then the specialty training in OBGY starts, and here the doctors who have finished their foundation years or have completed or have equivalent training who wish to become now OBGYNs must apply for the selection onto the National Specialist Training Program, which is ST1 to ST7. So there is 7 years of training in OBGY there. Okay. Then what is NTN? NTN is National Training Number. The trainees are given NTN number from their respective DNRE, which will remain with there until they attain a CCT. Right? So this is the national training number that they get. Now, people who have got this NTN will be given the preference over the overseas candidates in getting a slot for Part 3 exams, as the curriculum requirement is they can progress to ST6 until they clear their Part 3. So I will be showing you now what are the examinations that one has to clear before going into the advanced training. So there are 2 exams, the Part 2 as well as Part 3 needs to be cleared, of course, before going into the advanced training. So when you become MRCOG, you are actually at the level of ST5. So you have completed 5 years of training, and there is advanced training which is remaining, after which you will be getting the CCT or the completion of training in OBGY. So the basic training we saw, it starts basically with the foundation years, the first 2 years of foundation years before the training in OBGY. After that, of course, they can opt for any of the specialties. Once someone comes into OBGY training, there is ST1 and ST2, and which is called as the basic training. Then the intermediate training are the trainees from ST3 to ST5. Advanced training people are from ST6 and ST7 years. Okay. Now the advanced training skills module, which is ATSM, right? So these are for the advanced trainees, which is from ST6 to ST7. And you will be seeing that there are many modules which are present in the core training that you see in the e-learning for trainees, and they are basically for the advanced trainees there. Again, you can have any subspecialty training after that if you want, for 2 to 3 years, depending on what you want to do research in. Now, starting with how the trainees are assessed there, okay, right? So what is workplace-based assessment? So they are used to evaluate the progression through specialty training program, and they are not necessarily used to demonstrate that you are completely competent in a procedure, but they are just to see what are your strengths and weaknesses. So do not take it as a failure or pass. It's basically for the improvement of the skills is what they are saying, right? So the educational supervisor will give you the necessary support through this workplace-based assessment, and uh, they will also help in the routine appraisals that you get. So you should take assessments throughout the year, because they, like here we have in India also, they have the trainees who take the assessments at the end of the year when they want to take up the exams, and then it becomes a problem then. Okay, so they have suggested that take assessments throughout the year, so you keep on getting the valuable feedback, and you should also complete all the assessment forms via e-portfolio. So they have to maintain their portfolio, which needs to be updated. So they have to write all the types of assessments that they go through, even the reflective practices or the incident reporting if they have been a part of it. Okay. Now there are different types of WPBA, three types basically: the OSATs, the mini clinical evaluation exercise, and the CBDs, which is the case-based discussion. The OSATs are objective structured assessment of technical skills. The mini clinical evaluation exercise will take care of how you behave in a clinical setting, and the case-based discussion of any incident you have been a part of. Now there are two types of assessment. We have seen it in the previous video, the formative and the summative one, right? So remember, formative are basically for giving the feedbacks, for the improvements, and for learning. Whereas summative is seeing whether whatever you have learned is right or wrong, and whether you're competent enough to take up the skill. Okay, so it checks you on pass or fail. So that is summative assessment. Now the ONG training program includes both the formative and the summative OSATs, whereas the mini clinical evaluation exercise and the CBDs are only formative. Okay. So the OSATs are the one of the workplace-based assessment tools, of course, and they are validated assessment tools that assess your technical competency in a particular technique, right? So as the name suggests, they check your competency in a particular technique and see whether you will be able to use this technique independently. So the formative is of course for the learning, and so summative we see whether you are competent enough to take that degree. Now the skills assessed using OSATs, what are the skills that are seen? So in the core curriculum, they will be saying whether you can do a diagnostic laparoscopy, like up to ST5, right? So they'll be also checking whether the diagnostic hysteroscopy is done very independently with you, or fetal blood sampling, manual removal of placenta, the opening and closing of abdomen, operative lap, operative vaginal delivery, cesarean section, perineal repair, right? And the uterine evacuation. There is also another procedure, OSATs, for the procedures where you wish to record your experience, which is formative, or competence, which is summative, such as insertion of Mirena, marsupialization of Bartholin cyst, and cervical circlage. You need not remember that any of these things, so don't worry. This is just giving you an idea of how things are assessed there. Just remember, OSATs can either be formative or summative. Now, the formative OSATs, which is also called as supervised learning event or SLE, give you the opportunity to practice and get the feedback for a given procedure. For example, I want to check, or I want to uh, uh, take up a diagnostic hysteroscopy today. So I'll tell my senior to help me or supervise me on whether I'm doing the hysteroscopy right or wrong. And if I'm not doing it the right way, the person is, or the supervisor is, can help me with in the formative OSATs. Whereas in summative OSATs, um, I will be telling the senior or the educational supervisor to check whether I am competent enough to do the hysteroscopy, and if I'm competent, then I will be signed off to do that thing. So from the next time the patient comes for hysteroscopy, I can be called up for doing it as I'm signed competent. If not, then I am signed as non-competent and will have to take the summative assessment again. Okay. So remember, the formative is also called as SLE, which is supervised learning event, and summative is also called as assessment of performance, or AOP. These allow you to demonstrate the competence in a procedure and progress in your training. And of course, they help in feedback and improvement. Now, there are a number of OSATs. So remember, there are a specific number of OSATs that you can go through. Formative can be taken up as many as you feel. So there is no limit to learning. Okay. And then you have to take the summative OSATs. There are, before the competencies can be signed off in your e-logbook, you must successfully complete each OSATs. Okay. So every box ticked for level 3 practice on at least 3 separate occasions. Okay, so on 3 separate occasions, you should have the competencies signed off. Now, how to undertake the OSATs? Again, remember guys, all these points that I'm telling you is just to understand how things work there. You just have to remember what are the types of formative and what are the types of summative OSATs, and a few more small details of it. So you don't, of course, you are not the people who will be taking up those OSATs, but this is just to tell you how the assessment is taken up there. So what the trainees do there to undertake an OSAT. So when you are ready to undertake an OSAT, meet your clinical supervisor, who will assess the procedure, complete the OSAT form on the e-portfolio, and record the date that each OSAT is signed off. So you have to meet the clinical supervisor. Okay, remember that. You must declare in advance whether the OSAT is going to be summative or formative. And remember, this is important from your point of view of part 3 also. So if you have uh, said that this is going to be a formative OSAT and you have done the hysteroscopy, for example, very well in such a way that your supervisor is saying that you are now you can become or take up a summative OSAT now you seem to be very competent in it, then you cannot request your supervisor to convert that formative OSAT into summative OSAT. Okay, so that is not possible. So whenever you declare in advance, and there must always be a distinction between the two, you won't be able to upgrade the formative assessment that's gone well. So you must involve at least 2 different assessors. So you cannot get the procedure signed off only from one person. So if someone is your friend, and then it's like, okay, sign me off for, or give me the form to as competency in this, and someone signs it for you. So it is not going to be like that. So at least there should be at least 2 different assessors, and you must not ask the same assessor for all those ads, right? So the consultant must undertake at least one of the assessment, and the senior sign off must be as specified in the training matrix. So there is a training matrix on how the ST1 and ST till ST7, the people should be, what are their duties and how they have to go through the assessment, right? So what all is needed to become a ST2 from ST1, from ST3 from ST2. So everything is written in the training matrix, and we'll see it in some time. So taking consent for a procedure is not a part of OSAT. Taking consent is assessed separately by using the mini clinical evaluation exercise. Remember that? So you must retain all the OSAT forms in your e-portfolio, and this allows the educational supervisor to review the progress. Okay. Once you have signed off as fully competent for independent practice, you should undergo annual OSAT assessment. That is one per procedure. So remember, there should be at least 3 summative OSATs per procedure, and the last one, the annual OSAT, should have 1 summative OSAT per procedure. So you must also keep the count of the number of each procedure that you have performed annually until you achieve a CCT. Before taking a summative OSAT, you must demonstrate on several occasions that you are able to perform the procedure competently, right? And bear in mind that it's not envisaged you will complete the OSAT successfully at the first attempt. But remember, it is not taken up as failure. That is why it is called as assessment. Now, what is the mini clinical exercise? This is a generic tool that is used to assess or test you and very different and varied competency. So the trainers will assess the trainees in history taking, clinical examination, formulating the management plans, communicating with the patients, and the professional and the interpersonal skills, right? So all this is seen in your mini clinical exercise. The mini clinical exercise should take around 20 minutes, and the trainer should provide feedback to the trainee immediately after the assessment. The trainee should organize the mini clinical assessment exercises within the range of the trainers. So the OSATs is basically for the techniques that we have seen, like the laparoscopy, the diagnostic lab, the hysteroscopies, and the other procedures, the MROPs. The many clinical exercises are for history taking, clinical examinations, how you communicate with the patients, right? Now, CBDs is case-based discussion, and it is for formalized case discussion between the trainee and the trainer. So they are designed to be a vehicle for direct feedback about the case under discussion. And the trainers will use the CBD to assess the clinical decision making, to see the knowledge, the application of knowledge, and each CBD should involve a different clinical situation. So not every time you should have an emergency case. So sometimes you can have a difficult case in the OPD, or how you have managed a very uh, a emergency case wherein there was more bleeding, sometimes a case which was missed uh, by the other unit members. So every time you come across a case which is interesting, you can have a discussion with your assessor, and that uh, your assessor or your supervisor will be checking whether you can what you have learned from that incident. Okay. Now, this is what I was talking about. Though it looks scary, you don't have to remember any of these things. It is just to help you to understand how things work. So, in case a question comes from any of these things, you can still be able to answer. So, remember, these are the skills that ST1, ST2 should have. So, there are different types of formative OSATs, and remember, the ST1 should be able to take up this formative OSAT for the fetal blood samplings, the MROPs, the uncomplicated cesarean sections, non-rotational deliveries, the ventouse and forceps both, and the surgical management of the miscarriages or the abortions. Okay, so that much should be known by the ST1. So the clinical skills, by the clinical skills, if the ST1 goes, the ST1 will be the first on call, right? They'll be coming and seeing the patients. The ST2 has to have the formative sets in the form of hysteroscopy, laparoscopy, basic ultrasounds, right? And again, this person will be first on call, and he should have developed the competencies in readiness to be the second on call by the end of ST2. And this person should have taken part 1 MRCOG, ST2, right? Now to become ST3, after doing the part 1, you can take up the formative SATs of hysteroscopy, laparoscopy, operative laparoscopy is simple forms of that like idasiolysis, ovarian drilling, and should be able to take the formative OSATs. Formative OSATs, that means learning the third degree perineal tear, okay? And this person will now become the second on call. The ST4 should be taking up the formative OSATs, that means learning the simple operative laparoscopies and the rotational assisted vaginal deliveries, all the methods, and this person again will be second on call. The ST5 will be taking up the formative SATs of intermediate operative laparoscopies like ectopic pregnancies, ovarian cystectomies, salpingectomies, oophorectomies, and again will be second on call. And the ST6 will be the advanced trainee, and of course will be into some specialty, and is usually the second on call, the ST6 and the ST7. Remember, once you become ST5, you have to finish up the part 2 and part 3 to become advanced training. Now, these are few changes that are made in 2019 and 2020. And remember that at least three summative OSATs should be signed or confirmed by more than one assessor. So not one assessor should sign all the three OSATs, okay? So remember, the ST1 should take up the summative OSATs of cervical smear, so should be competent in that. The ST2 should be competent in cesarean sections, the non-rotational deliveries, the peritoneal repair, and the surgical management of miscarriages and termination of pregnancy, the endometrial biopsies. The ST3 should be in manual removal of placenta, transabdominal ultrasounds of pregnancy, early pregnancy and late pregnancy. The ST4 should be sound and should take up the summative assessment of hysteroscopy, laparoscopy, diagnostic one, third degree perineal tear, surgical removal of retained pregnancy of conception and vulval biopsy. ST5, who is now competent with exams of part 2 as well as part 3, should be also be able to take up the summative OSATs or be competent in the simple operative laparoscopies, endometrial ablations, so cesarean sections of intermediate grade, and the rotational assisted vaginal deliveries. And of course, after that, you should be you become an advanced trainee and should be able to do a higher level of competencies should be there with you. These are the assessments that every trainee should undergo. So remember, there should be at least 8 clinical, mini clinical evaluation exercises that should happen in 1 year. Again, so that this is for all ST1, ST2, ST3, all the till ST7. So there should be 8 CBDs for all the trainees in 1 year. Reflective practices should be taken up. 8 reflective practices at least should be taken up. Simulation training, there should involve one formative OSAT, that is basic laparoscopy skill for the ST1, and for ST2 it should also have the basic laparoscopy skills if not done in ST1. There is regional training, which is attendance at the regional training program as per the regional guidelines. Say, for example, there is the cervical smear screening program. So depending upon whatever regional teaching is there. There is again the TO forms we have seen. These are the feedback forms, and the TO1 should be taken up at least, that means the feedback should be taken at least twice per year as per the RCOG recommendation, and the summary should not raise significant concerns in the ARCP. So the feedbacks shouldn't score very less. And the clinical governance, there should be one completed and presented project by the ST1. There should be evidence of attendance at local risk management meeting. And remember that even the ST5 should have one completed project, which can include supervising the junior doctors. Okay, so that's why you are taught about teaching your juniors. Okay, so there should be teaching experience. In ST1, there should be documented evidence of teaching the medical students, the foundation year trainees. ST2 should teach, the ST should have the same teaching experience as that of ST1. ST3 should have organizing departmental teaching meetings and also teaching the FYs, the GPs. Uh, ST4 same as ST3. ST5s should also take up the teaching of all the trainees up to ST4. Okay. ST7 can meet the standards required by GMC and become a clinical supervisor also. Then there are leadership and management experiences which are seen, and they check whether the a person is able to take up the rota work, they can do the office work, they can help in administration. Okay. So of course the things increase and the expectations increase as your training years increases. Then the presentation and publications should be done annually, and they will do the annual review discussion of each one of them, and they will also be taken up in your appraisal. And the trainee evaluation forms, which is also called as TEF, needs to be completed on the e-portfolio. Okay. So the trainees will work with direct supervision, that is first on call, until they have confirmed the competency to work without supervision. Then they become second on call. The OSATs showing the evidence of competence are required for LSCS, assisted vaginal deliveries, the manual removal of placenta, perineal repair, fetal blood samplings, and evacuation of uterus. Okay, so they should be able to work without direct supervision, at least for these things, wherein which can be required at any point of time because the consultants will not be available at night. Confirming the competency should be supervised by the consultant. It is advised that best practice is for the transition from direct to indirect supervision. What it should take up in the same unit, and that is why it's been said that the ST1, ST2 should be from the same unit, and therefore it recommends that the ST2 should usually progress to the ST3 in the same unit. Remember that the OSATs should be supervised by one by the consultant or your educational supervisor, and the another one should be by it can be taken up by any of your senior trainees. Okay. Now, the summative OSATs confirming the competency can be undertaken by the ST6 or ST7 also for ST1 to ST5. However, more than one assessor must be used, and a consultant must undertake at least one of the assessments. So remember this because this can come up as a question. Now, what is ARCP? Very important to know. This is annual review of competency programs. So basically like your final exam. So you should ensure that you have achieved all the standards for your training year in the training matrix of educational progression to ensure the satisfactory process. And you and your educational supervisor need to meet to complete the educational supervisor's report together and record the educational achievements and the competencies that you have completed that year. Okay. So your educational supervisor will complete the structured reference section of the report, and the person will the educational supervisor will take up all your TO1 forms and summarize them and form the TO2 form, right? So you must also complete the trainee evaluation form on your e-portfolio, and there are different outcomes. So what are the outcome one means if the evidence provided at your ARCP is satisfactory, and then the panel will recommend as outcome one, indicating that the successful transition to the next training year. Okay. Outcome two is if there are any deficiencies in your training or areas of poor performance, then you will be recommended as outcome two, which is recommendation for targeting the training to help you address the issues. And if you complete this targeted training successfully, then you will be given the CCT, or then of course you will be progressed. Then outcome three is when you require a formal additional training, that you require a training program, and then they will say that you have got outcome three. And outcome four, if you are insufficient, you still have, you are lacking in despite having one additional year. So in spite of picking up a year, you still require more additional requirement, and you're still not competent, then you will be given the outcome four. Okay, which would release you from the training program. So outcome four, of course, will, once you prove that you are competent, then you will be you are still not able to remain competent, then of course there'll be actions taken up against you, and you even you will be out of the training program then. So of course this is scary. So nicely, you require a bit of help somewhere, and if that is done, you can become the you can take the forms, your certificates. Outcome three, you require 1 year of training. Outcome four is of the training program. So what is your final ARCP? So within 6 months of the anticipated CCT, you will be called for the final ARCP, which will review the entirety of your program. It will see whether you have issued or you have completed all the required assessments. Then you'll need to submit your outcome 6 form. So they'll be giving you a form which is called as outcome 6 form to the education policy, and then this will be the secretary of the Special Education Advisory Committee at RCP will contact you, and then they will recommend to the GMC that you have completed the CCT and you're given the completion of training certificate, and that's how you become the consultant there. Okay, so that's me saying thank you. I know that this looks very difficult, a little confusing, but go through it. You will be asked about assessment. You will be only asked about what are the duties of the supervisor. Now you have the idea of the supervisor. You have that there should an idea that there should be at least 3 summative assessments about one procedure, right? It should be signed by at least 2 assessors. Remember these few very things that I have mentioned specifically in this session, and apart from this, you need not know anything. So once you have gone through this session, just make notes of yourself. There are hardly 5 to 10 points